It is now week 5 already. We're almost halfway through. I want to tell you this is a good week to start to get that 250 word APA paper in. I know that community is going to have an exam, and then I'm going to have another exam with PEDS with you. So it's actually that week if you want to get something started, because week 8 is going to be really hard to get it all in. So it's just, if you can, you can. I would highly suggest. Remember, I do need the name of your diagnosis, all right? So bring it in. I don't want to have 10 of one diagnosis. 2 or 3 of one is about all. The rest need to be different. So this week, you've already taken your quiz. There's another discussion question, and there is a CJ Sims. You all been pretty well with turning them in properly, making sure you have your name, the sim on there, the date done, and the grade. That name in that upper right-hand corner is the important part. And most of you already have done that. Now, Max, so what topics are already taken? Well, in module 8, in week 8, that in the module, you're going to see a list of a bunch of diagnoses. You do not have to choose any of them. Those were just ones that I came across doing clinicals. I had a couple other professors put some in there. So it's a whole bunch of topics in there, but you could choose something that's more near and dear to your heart, something else. Just clear it through me. I'm very open as long as it's something that you can do an assessment on and teach something about it. That's what I'm looking for. So, okay, you all did pretty well on the quiz. I'm very glad to see that. So let's go ahead. Let's start with the PowerPoint. Any questions? Now, this is a rough week, guys. It's a little bit hard. Try to follow me as I go, especially when we get to the cardiac side, because heart in children and heart in adults are apples and oranges, except for heart failure. Okay? So when you think, well, I'm really good in the adult world, it doesn't translate, and we'll go into that and you'll see why. So let's start out with breathing, respiratory, airway, 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 right? So children get a lot of this upper airway stuff, that upper airway mucus, nasal mucus goes up into the ears, it goes down into the throat, and it creates problems. Then, we get it down into the lungs, and those would be like your pneumonias, et cetera, et cetera. Now, most upper respiratory infections in children are viral. The one that you always hear about is this thing called RSV, or a respiratory syncytial virus. And when you hear about that, it's usually when we talk about infants. Now, for you and me, you could see the difference in diagnoses and symptoms from an infant up to an adult. Now, an infant is very sick. They're in respiratory distress. They can barely suck, swallow, and breathe. And then you put mucus in their nose trying to eat, and now they're really in trouble, okay? And you can see you don't always have a fever here. And if it is, it's usually that little low grade, just enough to bother them. And adults is when we get sick. It's when we're blowing our nose, sore throat, cough, headache. That's normal for us. But as infants, it is something that can be too much just to suck, swallow, and breathe. Um, we do have an immunization for RSV. We give it to those infants that are immunosuppressed or were born premature or has other conditions that giving them also their nose clogged up and trying to breathe and feed is too much for them. We'll be starting them on something called Synagis. Okay? And that is the immunization for RSV. Now, children, when they're born, you're born with mommy's antibodies, but they go away, just like blood cells go away and they die. So your immune system's going away, your hemoglobin hematocrit, you're losing it. So you start with a 14, and by 6 months, you can be down to a hemoglobin of 10. Very normal. But now your body's starting to make cells, just like mom stuff wears off. And we know when mommy's antibody starts to wear off, when you start to see that infant getting those upper respiratory ear infections, cough, sore throats, because they don't have that immune system against it. Now, we hit them hard at 2, 4, 6 months with a lot of immunizations, but that's to protect them against those bad diseases. You're talking things, mycoplasma pneumonias, and those things are, they can't, pertussis and polio and tetanus. And those things are something that are really too hard for an infant to fight, especially, those immunosuppressed ones also. So we know that the infection rates go up when mommy stuff goes down, but what does that do? Especially toddler preschoolers, they're swapping spit all day long in daycare, school. That's just what they do. They are transmitting germs back and forth. And actually, they are giving us our immune system by doing that. Because now you know, we're getting those germs. Now our body has to make their own antibodies, and those children now are getting better immune system because of it. We know as we get older, it's now not necessarily viral diseases. It becomes more of bacterial, as in a mycoplasma pneumonia. And of course, immunity does increase with age. Of course, you're exposed to it. Your body's making all those antigens and antibodies to fight it. Most common of all things that you see children get is ear infections. It is the middle ear, it gets swollen, it gets full of mucus. It is bacterial. Remember, your oral pharyngeal airway, there's staph in there all the time. But then it goes up into your ears, and now it becomes a problem and it is painful. So we do give an antibiotic. Usually the antibiotic we give is a penicillin of some sort, like amoxicillin, augmentin. That's usually first line drug for it. Now, if we're seeing that this child is continually getting ear infections, then they might do that surgical intervention, which is tubes put in your ears. And believe it or not, I had a tube put in my ear just a year ago, into my ears, because I have a hard time, with my middle ears and sinuses and mucus. So I know what ear infections are. I know what it feels like to get a tube in because I had it done in the office, and you feel really dizzy when you're done with it. So, nursing care, otitis media, what's our biggest nursing assessment? Our biggest priority with otitis media? We know we have an infection already. Our biggest priority on a child would be pain. What do you think about that, Linda? Pain? Absolutely. One dose of antibiotic is not going to cure them, but we can alleviate the pain till the antibiotic kicks in a day or two later. Okay. So, why do these ears get all these infections? Well, infants and children get these short, wide open little tubes, and the mucus goes from areas of resistance to least resistance, which is the ears. So if that's the escape hatch, goes into the ears. Those eustachian tubes are short and open, and that's what happens. Now, what do you see when you see a kid with ear pain? Well, it is like, you'll understand. They'll be holding their ear and they'll be whimpering, they'll be crying, they'll be pale, they might be nauseous, they're not going to eat. They may or may not have a fever with an ear infection. And you might see, all that cough and nasal secretions and whatnot. But usually when a child is sick, especially younger ones, they're not like adults. Adults will continue on, they'll eat, they'll drink, and they'll keep going on with life. Children know. When they don't feel well, you'll see them sitting down, maybe laying on the couch or sitting in the corner, just not wanting to eat their favorite foods, drink their favorite foods, and just look miserable. And then what do? Well, anytime there's a fever involved, give them their acetaminophen, give them the ibuprofen, and then the fever comes down. Children are resilient. Once the fever's down, they're up and out and moving and they're running, and they are, drinking and eating, which is what we want them to do. So our goal with anything respiratory is we want them to breathe easier. We want them to be able to rest. Like, for instance, bronchitis. That's that dry cough that's worse at night, where it keeps you awake all night long because you're coughing, 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 coughing. So we want to, make sure that we can rest. Preventing the spread of infection, teaching children washing hands, using tissues, using the bend of their elbow, etc. Keeping the temperature down will promote hydration and nutrition. And of course, big hugs, kids like that. Now, there's something called mononucleosis, and all of you think that this is the kissing disease, right? When you think about it, well, it's a sore throat, fever, flu like, swollen lymph gland sort of condition. And it's the type where you feel miserable because of that extreme fatigue and that fever with the sore throat, and they'll go to the doctor and they'll do an influenza test because they always do that. And they'll always do a strep test and look at that and a culture, and everything is negative. So the doctor sends you home on a viral treatment: acetaminophen, ibuprofen, alternate, plenty fluids, rest. That's, what they start with. Well, a couple days later, they're still not feeling well. So they either go back to the doctor or urgent care, and they say, well, you've been through the testing, everything's negative, but you still don't feel well. Let's put you on antibiotics. So they'll put them on that augmented, amoxil, one of those like that, and send them home. A couple of days later, they're still not feeling well. And that's usually on Saturday mornings in the ER where I worked that I would see these children. And they would come in still with the same complaints: extreme fatigue, fever, sore throat, headaches, body aches, lymph nodes swollen, etc. And the doctor comes in and said, okay, let's draw some labs on that child. And what we'll do is this. Well, number one, we need to determine if it's bacterial or viral. How do you do that with a blood test? That's the CBC. Your white blood cell count will be elevated if it's bacterial. It's not elevated, it's a viral condition. So that's telling us something there. We'll also do something called a mono spot test, because that sore throat, not healing lymph nodes this is what this sounds like to mono, because you've gone through all the steps: a viral treatment and then a antibiotic treatment, and you're still bad. And most likely it will come back positive. Well, what is the nursing care? You think kissing disease, it's not a big deal. Can I tell you a story? I had an 8 or 9 year old little boy and his father come into the ER. Everything I just said, this whole scenario, exactly like I just said. On a Saturday morning, comes in, still complaining of all the symptoms. We did the blood test. We got CBC, white count was normal, everything was normal, positive mono spot test. So we sent him home. Now, what are the big precautions about this? Well, we told the father, we told the child, the physician told them, and I had hand out discharge instructions, and I even went over it clearly. The biggest thing, it's a viral. Acetaminophen, ibuprofen, alternate for fever, discomfort, plenty of fluids, rest. And the biggest precaution is the lymph nodes are swollen. The spleen, the liver may be swollen. And it's like a big ball. And if you hit it like a balloon, it can pop. So now protect your abdomen so that if it gets hit hard, your spleen can just burst and you're dead. Or the liver can burst and you can die, because all of that vasculature in there. All right, let me tell you the end of the story of this little boy. 1 week later, I'm the trauma nurse, primary trauma nurse on duty, which means any trauma that comes in, I'm in charge. I make sure that everything's done and I document it. This boy was out on the back of a ATV in the Everglades with his brother, fell off, fell on his abdomen, was brought in by a helicopter, and he was dead on arrival. He burst his spleen. So I think now you understand the teaching of no PE, no sports, no monkeying around with your brothers and sisters at home. Protect your abdomen. Okay. And they can't go back to sports until they're cleared by their doctor. So that's one thing I didn't know about, how severe it was. And it's something I try to share with you. And even with all the teaching I did, there's nothing I could do. The child still, but to this day, it still bothers me. So I mentioned bronchitis and cough and rest and comfort, right? Well, bronchitis is that dry, hacking cough, non-productive, worse at night. This is the one that you're coughing all night long. Even your ribs hurt. You've coughed so much. Your throat hurts because you cough so much, and you're taking, antipyretics and cough suppressants and whatnot. But usually it ends up with a narcotic cough medicine that will help suppress it. But today you can't get it. It's one of those impossible drugs that you can't. But there's many choices: cough suppressants, using lozenges. There's things like Tessalon pearls and whatnot. But the goal with bronchitis, because nothing comes up, it's just this dry thing, is to suppress a cough. A lot of times we take these children, put them in the bathroom with the steam on, or I know parents that will take them out in the car for a ride because the night air helps with the cough. All of these things, that's bronchitis. Now, there's another thing called croup. This is the one that the child barks like a seal, and it's like really loud, distinctive. You could be in a big busy ER and hear a child with croup cough, and you're like, oh, that's croup. Very distinctive. Now, croup is upper airway oropharyngeal swelling, and that swelling creates inspiratory stridor because it's upper airway swelling is hard to get air in, but it comes out easy. So inspiratory stridor. If we don't treat this, then it's a viral infection. So usually there may or may not be a little fever with this. It's the cough that's this big annoyance that can lead to respiratory distress and collapse. Okay. So how do we treat it? We just give them steroids. We decrease the inflammation, the airways open, air gets in, inspiratory stridor gone. Sometimes we don't get to it quick enough. And this acute laryngotracheal bronchitis or croup, same thing, same name, which is usually, as I said, due to a virus, can become worse. So as I said, inspiratory stridor. With that, you might have some retractions, and you'll always hear that seal-like cough. If it's not treated, it turns into this. Now, where is the epiglottis in the body and what does it do? The epiglottis is that thing, that leaf-like structure that covers the trachea when you swallow food or liquid, so food don't go down into the lungs. Well, that leaf-like cartilage thing swells up, covers the trachea, air can't get in. It's that swollen. This is a true, real emergency. We need to decrease that swelling. We need to get an airway open now. What does that child look like? If they're to the point of the medical emergency of acute epiglottitis, they're going to be like in that old lady COPD, frog bent over position, trying to find a place where they could get a little air in there. They can't talk, or their voice would go, oh, 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 because it's so swollen in there. All of the mucus in the mouth, they can't swell because it's all swollen. Nothing goes in. So they're drooling. So can you see this child drooling, inspiratory, can't breathe? So what do we do? Well, these children should be placed in an area quickly, most likely a trauma room, because they might to be intubated, and they need an intubation and or a tracheostomy tray at bedside. That's priority. Now, you don't have to get it. Send the secretary, send the nursing assistant, send somebody, go get it and make sure it's here at the bedside, because airway, airway, airway. So how do I treat this? Well, the easiest way to get that swelling down is to give this child epinephrine, and we give it in an aerosol. So when I hear this coming in, I run and get myself out of the medication Pyxis, racemic epi equipment, and run in the room and start it. And now that, and it's like a 2 or 3 minute aerosol. It's really itsy bitsy little bit. And they get it in and it starts the decreasing of swelling. And then we're going to be putting them on mist oxygen just to make it easier because we don't want them struggling. Get an IV in them. We might even give them epi sub Q. Of course, steroids absolutely will be given. And if the child can't breathe, they're not going to eat or drink. They'll get IV fluids. And then wait till later on where their airways open, then they can have a little bit, maybe a fluids later. But this is a severe and true, real emergency. Now, that RSV is that little virus. It's a common cold for you or me, but it's not really nice for young children. Now, goes over a little more. Now, RSV is also called bronchiolitis. It's the same thing. It's just a different name. It's usually from winter, early spring. This is up north more than down in Florida because we don't have that changing of season as much. There's a little slight one, although this winter has been pretty cold for us down here in Florida. But that's when usually you see the RSV. And what we do is a monthly vaccine. Remember, these are immunosuppressed, cystic fibrosis, sickle cell, premature, lung disease, cardiac children, all would be apt to get this. It's called Synagis, and then the name is called bevacizumab, and you can see that's a biologic that they give once a month only for the first year of life. And that's to help prevent from getting this virus because suck, swallowing, and breathing is enough. Now, what's the biggest surgery children go through? They go through their tonsillectomies, don't they? TNA, TNA and tubes, T. Well, let's go and look at post-op treatment. Well, we know
Adenectomy too.
preoperative treatment, you know that we're going to be wanting to get them already on their developmental level and all of those things. I mean, that's for sure. Post-operatively, this is when they come in, they do surgery, and they usually send them home. It's better to recuperate at home, they found, post these types of surgeries. So we need to teach them. Avoid irritating or highly seasoned food. It'll burn the area. Avoid gargling and vigorous toothbrushing. Can I explain to you what they do to that surgery? So your tonsils and adenoids are these big things, out patches in the back of your throat. They literally cut and cauterize these highly vascular areas, and what's left is scabs. Can you imagine? So if you cough or do something, you could pick the scab, and guess what? You're going to bleed. And I'm telling you, I have seen 7 days post tonsil TNA come into the ER, vomiting, hemorrhaging blood, clots the size of softballs that required resuscitation, fluid resuscitation, and she was sent back to the OR to get that area cauterized. So tonsil's not a big deal, right? It's a big scab. You need to follow these orders, right? No can make it come up. So that's a little girl who likes, or little boy that likes to clear their throat. It wouldn't be a good time to be doing that. Using analgesics, today, all we use is Tylenol. Years ago, you used to send them home on a little bit of codeine, that liquid hydrocodone, I guess it was called. And they found out that they were overdosing on it. It was too much, and that Tylenol was just enough for it. Now, ice on the throat helps. Young itsy bitsies don't want it, but some older kids will put it there, but it does help. Nothing in the mouth. If they want to eat, they got to be careful with it. Um, they should be more on bed rest. They're up and around, running around with their friends or their brothers and sisters. And older children, they get these ears get full up from the surgery. Chewing gum is like going up in an airplane and you could pop your ears. Well, it's the same concept that we use for your tonsillectomy. Now, you're going to have a mouth, a breath that stinks, right? You got those scabs that are healing. So the breath is not going to really smell that good. But if we see it over a week or so, and there's a smell and there's a fever continuing, that could be an infection. But it's that really fine line. When is it? But anything severe, severe headaches, fever's too high, etc. Of course, you got to get back to the doctor for that. Now, pneumonias could be caused of many different reasons. One of the things about pneumonias is I used to love to try to find these in the children that used to come through for me. These children would come in and they would be saying that the child's come in and has a cough, vomited once, and has a fever. So I listened to all the lobes of the lungs and usually left lower lobe. I swear to goodness, that left lower lobe is the one that was hit probably most, and you heard it decreased. So we send these children for an x-ray, right? So when they come back, me and the child, because I want children to know what's going on so they can take care of themselves. We're going to look at the x-ray and we're going to go, oh, look, see that white thing there? That's where your pneumonia is. So now we got to cough good to get rid of it. And children, when they see it, understand it, right? Remember, up to school age has to see it before they can do it again. It's only the adolescents that can be more creative. So teaching is a good thing for your young children. So pneumonias can be anything, right? From anywhere. We know we have a good vaccine out for the pneumococcal. That is one dangerous pneumonia. Now, the other pneumonia we don't think about is what we call aspiration pneumonia, right? This is when they're eating and they're aspirating and refluxing. That could be. And how would that happen? Well, we need to teach, of course, our mothers that are feeding how to burp properly, how to sit up afterwards, not to overfeed, all of those things that can help prevent, all of this reflux. Another thing that can happen is, I used to love Johnson and Johnson baby powder, and the newborn ICUs used to have it many years ago. But then we realized it's that powder in the air, it's getting in their lungs, and it's not a good thing, and that could be aspiration pneumonia. So we don't use that. Also, not being around big smells. If you're cleaning your bathroom, there's bleach in there and there's a horrible, chemical smell, you wouldn't bring your child, especially small children, in that room to breathe it in. And that's what that's talking about. Now, foreign body aspiration, that picture down there depicts the coin that is mostly swallowed by children. It's not a dime, it's not a penny, it's not a nickel. They like quarters. I'm like, why did you pick the biggest quarter if you're going to put it in your mouth and you're going to swallow it? Now, most of these children who have swallowed a coin, and I find it, they're breathing, they're talking, they're a little scared because it hurts. They can feel it there. And we do an x-ray and there it is. How do you think we get that coin out of there? My grandson did this a year ago at age 9 years old. Well, today, what we decided is we will, and when I first saw it done, I was like, oh, this is interesting. We used to take him to the OR, right? Do a bronchoscopy, go down, grab it, pull it out. A kid who's old enough that you can talk to, sit him on the surgeon's lap, mommy and daddy, everybody there holding hands, and me telling him he's going to take a Foley catheter with a balloon, pull it down the throat, below the quarter, blow up the balloon, lean him forward, and say, cough. He coughs, mucus, and the coin comes up and falls on the floor. And before that happens, I say, when he pulls that out, whoever gets that coin first wins and can have the coin. Of course, I look like I'm going to go get it. But the kids on the floor getting the quarter forgot what happened. They're not nervous. And we just watch them a while, making sure airways open. So again, do you see how I distracted a child? And I'm talking all age children from 4 to 10. I've seen coins down there. Again, I've seen French fries being inhaled where they couldn't come out, where they ended up on ECMO and actually died several days later from a French fry inhale. So, foreign bodies. How do children explore the world in their mouths, right? So, it's a difficult thing. What's that in your mouth? Get it out. My 8-year-old grandson, to this day, everything in the mouth. If not, it's the shirt in the mouth. It's just part of what children are. But can you see what can happen? And it can cause them to die like that French fry did. Now, pertussis. We mention it because pertussis should not be here. This is something that we do have immunizations for, but there are some families that don't believe in immunizations. And it's not my right to say whether they should or shouldn't. I mean, I would tell everybody they need to because I'm immunosuppressed. And what they're doing is they're causing the more perhaps chance that we're getting these diseases spread because they don't have an immunization. So again, just like chicken pox, first thing I'm going to do if you suspect anything, I'm going to put on the mask, put them in an airflow room, protect myself, protect my other children in my department. Okay. And pertussis is treated by azithromax, an antibiotic, and it is airborne. Smoke inhalation, know that whenever children are in fires, always know if there's burn where they are. There's burns in the face, always worry about airway. And again, even if they're in this hot, smoky environment, that humidity, oxygen 100%. I've seen them go into hypobaric treatments before with smoke and those things also, if your hospital has them. Um, Smoking. Smoking affects all people. It affects, the unborn child, of course, but children, it can cause them get more ear infections. Smoking can cause an increase in SIDS death. So smoking should be avoided around children. Now, cystic fibrosis. Cystic fibrosis is an inherited disease. Um, you need both genes to have it. And then, of course, 25%, very similar to sickle cell disease, the sort of chances of it. Now, how would we know a child has cystic fibrosis? Well, was either a history of it, so we knew, or newborns born that have cystic fibrosis are, quote, constipated, which means they are not going to move their stools, their bowels in 2 or more days. And that's when we would suspect cystic fibrosis. We'd also suspect other things, but that's the first thing I want you to know. Cystic fibrosis sometimes is determined at birth because of a lack of bowels being in the first couple of days. I mean, think about newborns. They come out, they're like immediately meconium stools, etc., especially if they're breastfed, right? Stools, stools, stools. Well, not cystic fibrosis, and it would cause it. Now, as they get older, now, a newborn with cystic fibrosis, um, I would tell the parent if she licked the child's skin, it would be like salt in her mouth. High levels of sodium are on the skin. It's excreted. So you have electrolyte loss with cystic fibrosis. Also, it is thick secretions in the lungs. So coughing all the times with infections, pneumonia, wheezing all the time. Cystic fibrosis also affects nutrition, and it doesn't allow the pancreas to secrete um, pancreatase, which helps with carbohydrate um, digestion in the body. So they're going to have poor growth. Carbohydrates is a lot of calories, right? So poor growth, poor weight gain. They're eating, but they're losing it. Now, even with that, if they eat too much fat in this diet, also, you're going to see these foul, smell, greasy stools. They are foul. And you can almost see grease in them if there's a lot of grease in the diet. So, We're diagnosing at birth, no stool. All right. How do we diagnose for cystic fibrosis? The name of it is called a sweat test. I'm measuring the salt in the skin, basically, right? That's it. And there's little probes they put on. That's all they do. Now, once we determine you have cystic fibrosis, what is going to be the treatment? Remember, we've got lungs and we've got small intestines nutrition. Two components. Both have to be treated equally. Okay. So we'll give antibiotics. We're going to give aggressive chest PT, making sure that we're keeping that music up and running. We're going to make sure that we're cleaning the equipment so that soap and water, preventing transmission from day to day, using aerosols, et cetera, et cetera. Another thing is we're going to do treatments and chest PT before they eat, right? We don't want to do it after because they'll vomit it up. So we do it before. Now, how do we treat? Now we treated the lungs. They're open and ready to eat. Now, these small intestines, how do we get them ready to accept food and to be able to digest it? Well, we're going to give them a pancreatic medicine before meals and snacks. Sometimes it's powder. And if it is powder, you sprinkle it on the food and rinse your mouth when you're done. The powder can hurt the enamel on your teeth. Sometimes there's these little capsules. Sometimes they can swallow them if they're older. Younger ones that we would take, and those beads, never, they're enteric coated. Never crush them. All right. Never chew them. They have to go down all the way. And we do it, hopefully, if we take the pills 30 minutes before we eat. So now the body's ready to digest the carbohydrates it needs for nutrition. One of the things I think that as a medical person, been around for a while, that I've really seen is that children get bigger, and in all conditions, seizures, cystic fibrosis, medications adjusted according to weight. So children some years can grow 10 pounds in a year. And again, we've got to adjust these medicines as they grow. So cystic fibrosis, what is the respiratory management? I said bronchodilators, minimum morning and night, sometimes every 6 hours, depending on the child. Again, if they get infections, not oral, sometimes by a PICC line, and they'll put it in the aerosol, tobramycin, gentamicin. They put them in the aerosol and it goes directly into the lungs. Now, diet. So we got the lungs, we got to work on them hard. And now the diet, the pancreatic enzymes. Now, besides just that, I told you they don't like fat, right? Fat's not going to be digested. Too much fat is just going to go through, and it's that greasy, smelly stools that are coming out. What we want to do is high protein and give as much calories as we can and keep away from fat, low fat. All right. They'll be able to absorb it that way. Again, monitoring the stools, making sure they're stooling. And then if there's any sort of reflux, of course, we're going to be treating it. Now, as children get older, there is a chance, because this is the pancreatic enzyme. So it's the pancreas that it's affected, right? And you're saying, isn't that diabetes? Well, no, it isn't yet. What it is a problem with fat digestion, but it's the pancreas. It can turn into diabetes. So it's something that we really need to be monitoring for, monitoring glucoses, A1Cs, et cetera, when they're being visited, okay? Things about cystic fibrosis is women can have babies, but they're high risk, okay? What if you have a man with cystic fibrosis who wants to have a child? Well, what they say is that their vas deferens, their testicles, is full of mucus, and there's no pathway for sperm to be able to get to the woman. So they say after 1 year of bilateral lung transplant, all of a sudden that mucus isn't there and they're able to get a woman pregnant. And there are men who do it just to be a father. Sleep apnea, you think just about adults, right? Well, you have little children who love to snore. And if you have kids who snore really loud, I know they get really tired and you hear this good stuff going on. Well, just like adults, there are treatments. Sleep study, yes, we do them on children. The TNA, that helps with it. Also, it can be on CPAP, BiPAP, just like adults can. Now, ARDS, this is the lungs, they're hurt for whatever reason. It could be infection, could be trauma, it could be drug overdose, it could be near drowning. All of these things affect the lungs, and mortality is high. You know, what you're looking at there is part of an ECMO machine, and all that blood going all over, it's going into that infant's little side neck. And, you know, just to show you things that we'll use on all age children, it's something that I had the opportunity to be certified in and really liked what it did and helped these children with. So CPR, you know, you saw a CPR question. 15 to 2 is going to be 2-man, 30 to 2 is your 1-man. Those were things. And another thing we got to remember too is that there's a family. When you have a family, you know, and a child is going through one of these episodes, again, keep the families involved when you can. I would hate to say that I had a child die that mommy couldn't be there holding a hand. You know, I think sometimes they know the inevitable is coming, but please, you know, let them be there. And I will never turn them down for that. Asthma. How many of you have asthma or have children or have asthma or know somebody with asthma? This is where you can get air in and then it swells and you can't get air out. So croup, air can't get in, is inspiratory. Asthma, I can't get air out. It's expiratory. So how do we treat asthma? Well, of course, pulmonary function, skin testing, what allergens? Is it a cat? Is it a dog? Is it the birds? Is it grass? You know, there's all different allergens and what it could be out there. They usually tell you to change your mattress, right? Or get the rugs off the floor, or all of those things can carry antigens. That picture down on the bottom left is the spacers. And you can see they're small, medium, and large. We use them on infants all the way up to the elderly. And it's to get that metered dose inhaler, the medicine gets into the child or to the adult. So we use those long-term control medicines like in children, Pulmicort. That's morning and night. There's a little bit of steroid in it, and it's to prevent bronchospasms. And then we have our rescue, our Atrovent, Proventil, albuterol, that dilates, okay? And then, of course, we have Singulair, which is what I call a asthma Claritin. Same sort of concept, preventing allergens. And of course, steroids that are used in case of big problems. Now, status asthmaticus is a true and another true emergency. I actually lived through status asthmaticus. My husband, he was having difficulty breathing. We got him to the hospital, and in the middle of the night, he had a bronchospasm, and he stayed in a bronchospasm for about 10 days. He ended up on BiPAP, all the medicines, steroids, theophylline, aminophylline, and everything. And about 10 days into it, he turned around. But when I listened to his breath sounds, all you could hear when he breathed out, not in, you couldn't hear anything. When he breathed out, I heard a, and that was it. There was no air coming in and out of it. Status asthmaticus, many of these times, they end up intubated, and then it's hard to get it off. I was very lucky. I had physicians who listened to me, and we never had to intubate him, but he was this close all the time. COVID, we know about COVID and immunizations, and there's all different, concerns with it. And now we're going to go into our heart. 42. So, hearts. We have a normal heart. Everything works the way it should, which is like amazing that a normal heart is formed. It starts with a stalk, turns around, twists, comes up and twists around and through intrautero. It's just amazing that more hearts aren't born, that don't have things where it should be. Now, most times when we talk about cardiac conditions and children, we talk about congenital defects. That means they were born with it. Now, it can be during time that they acquired it. Usually it's the infection, autoimmune. Autoimmune could be like lupus could affect the heart, right? Autoimmune. Infections, overwhelming sepsis could cause that too, myocarditis, etc. Now, the first thing I want to do is trace a drop of blood with you. So you're going to remember the anatomical things in a heart, okay? So let's start where the blood just comes back to the heart. Superior vena cava, inferior vena cava. Goes into the right atrium. Goes through the valve, tricuspid valve, into the right ventricle. Then it goes up the pulmonary artery into the lung. Then it comes back into the left atrium. There's actually 4 pulmonary veins. I never knew that until I worked cardiac. Through the mitral valve, into the left ventricle, the aorta, up the aortic arch, into the body. And then it goes all the way and it comes back. Okay? Now, why do you need to know that? Well, when we start talking about heart conditions, I want you to think of a garden hose with a kink. If there's not an opening or a narrowing, think of kinking it and thinking the water on the garden hose will go backwards. Where's the outlet going to go? Like a squirting out piece of water, right? Well, if I kink that aorta, it's going to go backwards into the left ventricle, left atrium, and it's going to fill up fluid into the lungs. Did you see that? Kink the aorta, goes backwards. Left ventricle fills, left atrium fills. Now the lungs fill with fluid. Now you're in a congestive failure. What is that condition called? There's a kink in the aorta. Blood can't flow down. That is called a coarctation of the aorta. Now, how would you know that's happening? Before all this stuff gets into the lungs and fills up, and now you're in congestive heart failure really bad. Well, think about the aorta. This is the big garden hose that comes down and feeds the whole body, right? So if it kinks, blood's not going down. What do you think the pulses in the feet would feel like? Dorsalis pedis, posterior tibial. They're not going to be really strong or non-existent. Once I see that, the next thing I'm going to do is I'm going to take a blood pressure of the lower extremities and the upper extremities. What do you think I'm going to find? Well, if blood can't go down because there's a kink, blood pressure is going to be lower in the lower extremities. And because the blood's going back up to the upper, and you've got those 3 little slots on top of the aorta going up to the brain, subclavian, etc., carotids, right? So it's going up that way. You're going to have higher blood pressures. You might even have nosebleeds if you were an older child, or even headaches with an older child. So garden hose, kink, which way does it go? That's what you have to think with some of these questions. All right, so I mentioned coarctation of the aorta. I'm telling you, the kid's just not looking right. And these are things that you would see. In fact, I had a little girl at 3 months old who finally got back to us after going through, I don't know how many hospitals, doctors, and finally we figured out, here in Miami, what was wrong with that little girl. And these were a lot of her symptoms. She was poor feeding. She was tachycardic. She was not gaining weight. She could not barely finish a bottle or eat, so activity intolerance. She couldn't lift her head up. She was 3 months old. She should have been starting that thing. She wasn't grasping. She just wasn't alert. Now, there wasn't any histories, but who knows? You don't have to have all of them. One of a nursing diagnosis that would be great here was inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. They're not eating, they're not gaining weight. Cognitively, they're not getting the fuel for their brain. This is what you're going to see. Now, what would you see in a child, cardiac child? Well, number one, you're going to be looking, yes, of course, the weight, cognition, all that good stuff. And then the visual, the color, the chest, looking at the way that they're breathing, etc. Putting them on a monitor. What does the heart rate look like? Pulses, what do they look like, feel like? It's the chest. Can you see it sometimes moving? Is there a retraction? All of these things looking at it. When cardiac children are admitted, of course, they're first placed on a monitor. First of all, we're going to do a 12 lead EKG. Let's look at the way the heart's beating. And then as soon as they can, what they do is they get an echocardiogram machine there. And we're going to look at the way blood's flowing around the heart. Now, the blood's not flowing the way it should. Immediately, they're going to be setting them up for a cardiac cath. And in that cardiac cath, they're going to figure out what's the structural problems. And then they do this cardiac conference and they determine what surgery has to be done. And some of these children are as small as that little one you see in that picture. And they don't know how they do surgery on it because this is a normal 5'11" amazing physician. I don't know how he gets his hands in there. I just don't. There's another thing with cardiac cath to know that it's not just all looking to see what's wrong. We can also, for instance, that interventional, that physiology studies. Sometimes hearts tend to have these little spurts of fast heart rates, and they can become annoying. And they go in and they find out where it is in the heart, and they can take a laser and zap it. So it stops them from having to be on medicines forever. So that would be what we call an EP study. I worked with it before, and I think it is amazing, to watch them go in there, create this SVT or tachycardia, fast heart rate, and then zapping that whatever area in the right atrium has caused it, and boom, it's gone. So you need to know how to take care of a child with a cardiac cath, right? So usually these kids, as I said, are newborns. We don't really keep them NPO. We usually will feed them up to about 2 hours prior to procedure because we don't want they burn up sugar quick. We don't want them to be without sugar. So, and send them to the procedure to get it done. Now, after the procedure, when they come back, these are your precautions. So explain what they do in the cardiac cath. Yes, it's like going to the OR, they'll intubate them and they'll knock them out so they don't move and hurt themselves. But they're going to take 2 big catheters and put it in the right femoral artery and right femoral vein. And they inject dyes up there and all things and looking to see whatever the heart's doing. Okay. They do this procedure and they pull out these catheters and they put pressure on these 2 areas, these 2 puncture marks. When they feel it's clotted enough, they put a pressure dressing on it. Older children will get a sandbag on it. Newborns are too small for sandbag. It's half their weight. That would be crushing them. But a nice, good, solid dressing. Now, then they take this child, put it back on their warmer or put them back in the bed, and they bring them back to your unit. And the first thing I'm going to check is the dressing. And why am I checking the dressing first? Those are like this big, how big the catheter were. And a child could bleed out very, very quickly. What would you do if that area was saturated with blood? You take 2 fingers, put it on top of it and push. Then you're going to call for help. You might need to give blood. You might have to do a CBC, something, but your job, push it. Just hold it there. And that's the treatment for it. And then get somebody to help you, okay? So biggest risk, hemorrhage from that catheter site. So once, okay, you get there, the dressing is good, it's dry, it's clean. You're going to be checking the pulse of that extremity. It's going to be decreased a little bit, but it's going to be good and perfused. And you're going to document that. And then you're going to put that off in your change of shift report, what that pulse feels like. And then if they need an IV, fluids, PO fluids, and we do a blood glucose, as I said, because did they get glucose during procedure? Do they have a good enough glucose now? So congenital heart disease, biggest one is a VSD. And the child more apt to get a VSD or some cardiac abnormalities are your trisomy or Downs children. Now, most of you think there's one type of Downs, right? Downs, it's trisomy 21. Well, there's 21, 18, 15, 11, and I actually saw 9. Now, you don't need to know that. I'm just telling you there are different numbers. The littler the number, the more severe the abnormalities. But the normal, the Downs child, 18, 21 is normal. And actually, when we see or suspect a Downs child, the first thing we do is listen to the heart. Is there a VSD? Is there another abnormality? AV canal is another one that they get. Or truncus. They're just, you don't have to know them. It's just they're really apt to get them. Now, congenital heart disease, know that there's 2 types. One, that you're never without oxygen. You always have a good saturation. That's called acyanotic. And then you have some conditions that if you have an O2 saturation of 75, you're happy. And that's okay to have that O2 sat 75. So cyanotic or acyanotic. Another thing you need to know is about blood flow, for instance. What would happen with the blood coming from the left atrium on a child that has a hole between the 2 atriums or an atrial septal defect? Well, look at the right side. Blood just got there, right? Just got there. It's the end of a beat. And that left atrium has 4 veins flowing blood there. So that's higher pressure, right? There's a hole there. It's going to go from most to least resistance. The blood's going to go back in, back to the right side, and it's going to be recirculated into the lungs. So an ASD, VSD can cause lungs to recirculate, blood to recirculate in the lungs. It's an important concept. So we've talked about ASD, VSDs, increased pulmonary blood flow. The other one that causes increased pulmonary blood flow is something called a patent ductus arteriosus. Now, you all had OB in intrautero. Mom has the baby and they're under fetal circulation. And what happens in the heart is the lungs and the body are connected. So you have this inner blood flow going on the infant when it's inside mommy. And that connection between the lungs and the body, or the pulmonary artery and the aorta, is called a patent ductus arteriosus. And that patent ductus arteriosus keeps blood flowing, oxygenated blood to the body. Well, after birth, mommy's not there anymore. And mommy secretes hormones that keep that duct open. And that hormone is called prostaglandins. Now, that prostaglandins, now mommy's gone and it's gone away. And most of the time, that's fine. It's what's supposed to happen. But what happens if you have a cardiac condition that there's no other way that you're getting blood flow? What if you had no connection between the right atrium and the right ventricle? The right ventricle has nothing going to the lungs. There's no blood. Well, we can keep that duct open, putting oxygen from the lungs to the aorta to the body. So I call the PDA the oxygen giver. You want oxygen? You need a PDA. We've gone over a coarctation of the aorta already. And then know that when you see stenosis, it's a narrowing, an O, it's narrowing. And then atresia, like tricuspid atresia, is without. And no pulmonary blood flow. Tricuspid atresia, blood can't get to the right ventricle. It can't get to the pulmonary artery. It can't get to the lungs. We are cyanotic, okay? Now, in exams, SC, NCLEX, they love tetralogy of Fallot. Cyanotic heart disease called tetralogy of Fallot. And what it is occasionally pulmonary artery spasms closes shut and blood can't go to the lungs and causes a TET spell. When that TET spells occur, there's no oxygen going to the body. It happened once to me on an infant who was 1 month old, little Nolan. I'll never forget him. 4 o'clock in the morning, was changing his diaper, cleaning his lips, making pretty, I like kids to look pretty. And all of a sudden he turned blue. He went from O2 sat of 100 to 10 in about 2 minutes. So what do you think we had to do to get blood flow going back into the lungs? Well, you take the knees and the chest and quickly push them together. And what that does, it changes that pressure in the abdominal cavity, chest cavity, pops it open, and it lets blood flow most of the time. If not, there's other stuff, but that's all you need to know. Knee, chest. Older kids that have not been fixed, all of a sudden you'll see them squat on the ground. They do this knee chest automatically. So mixed blood flow, transposition of great arteries. When your right ventricle is connected to your aorta and your left ventricle it is attached to your pulmonary artery, they're switched. So you have lungs and you have body, and we have no oxygen getting anywhere. So what do you think we need for this transposition of great artery? We have lungs, oxygen. We have body, no oxygen. We need the oxygen getter. We need to keep that PDA open to keep oxygen going to the body. So there's a PDA. It's talking about it some more. What it does, at birth, you can hear it. It sounds like a washing machine murmur. It sounds like it's really a washer machine. Another thing that we do here with the PDA, even before we listen or do a echo or anything, when they have this, what we call a wide pulse pressure. Now, at birth, a normal blood pressure on a newborn infant is 60/40. Like me and you is 120/80, right? This is 60/40. Well, when you see that diastolic number 18, that's a PDA. And what's interesting is as that PDA starts to close, that 18 is going to turn back into 40. And the way that we close it is through this medicine called indomethacin. It's given IV, 3 doses. And how do you know it's worked? Well, that pressure is going to go back to normal, and that murmur is going to go away. It's going to stop. Easy to sit, look at that. Now, that transposition of great artery where the blood isn't mixing, there is no connection, you need it. We need to put on something that mommy had before and now doesn't have, which is the prostaglandins. So we do have synthetic prostaglandins. It's a slow, very slow, continuous infusion, and it maintains cardiac output and oxygen saturation levels because now the oxygen getter is there. So I left these in there to show you them, but I've basically told you all about the different connections, etc. Now, congestive heart failure, we mentioned it, and we mentioned it with coarctation of the aorta. Now, coarctation of the aorta, fluids filled up into that lungs, and now the kid cannot breathe, it's full of fluid, and now the heart's being stretched, it's damaged, and the kid's just short of breath. So lungs get full of fluid. We know that. Now, one of the ways that we can look at, especially congenital heart children, when they come to us and we think that, or as they're staying with us, we will do a weight every day. If we see them gaining a lot of weight overnight, this is congestive heart failure, and we need to be aware of it. Tell a physician. They gain a half a pound overnight, something's wrong. So that'd be something we would tell the doctor. So what are we going to do? What's our goal? Congestive failure, full of fluid, not breathing good. We want to get that heart beating better. It's stretched out. We're going to give medicines to help it beat more efficiently. Maybe digoxin. It's a good one for children. We're going to remove fluid and sodium, furosemide, diuretic, absolutely. Decrease cardiac demands. Maybe we weren't going to feed this child. Maybe we'll give them a tube feeding while we let that heart rest a little bit. And that will improve tissue oxygenation also. Now, giving digoxin, just like giving it to an adult, same things we look at. The only difference, heart rate would be below 100 that we, for an infant. But usually your physician will tell you, because we know children are all different ages. So you count apical for a minute, check electrolytes, specifically the potassium. Is there a drug level? Infants can't tell you that they're nauseous or see yellow spots or anything like that, which would show toxicity, right? But if an infant is vomiting, I would rather be safe, not give a dose of a medication, get a drug level, and then give it if we are not, too high. That would be the safest thing to do. So with these children, we want to, have them rest. We want, of course, nutrition. Without nutrition, you're not feeding the tank. And again, parents are scared. They're really scared at this point. When infants have these conditions where they have these cyanotic defects, the one I didn't mention was a hypoplastic left heart syndrome, most severe of all cardiac conditions. The left ventricle doesn't form completely, so you don't have a pump for a heart. And these children, as they get older, will always have lower saturations. When a body doesn't have, quote, normal saturations, the body's going to try to help by producing more red blood cells. They figure more red blood cells, more oxygen, right, going to the body. But it's not the point of the red blood cells. It's that there's no oxygen because this is a child who is cyanotic, who does have a lower oxygen saturation. Do you know it's not uncommon for these young children to have hemoglobins like 18 and 54, where normal is 14 and 42, right? See the difference? It's because of the polycythemia. The body's making red blood cells. So again, it's always, you're going to find out if you ever work in the cardiac unit. It's my favorite of all time. I absolutely love the cardiac ICU. Families, if they're always the nicest, and they're always willing to sit and learn and understand what's going on with their child. I went over cardiac cath already. Bacterial endocarditis, just know it is an infection, and there's going to be some high dose antibiotics and prophylaxis with it. Rheumatic fever is one of two different diagnoses that is caused by a strep throat that wasn't treated. Number one is rheumatic fever. And these children come in and they're complaining, of course, of the sore throat, their joints, they've got rash, they've got this crazy movement called chorea, where they're not moving correctly. And they come into the doctor. And again, we need to find out what happened. So when we see these things that we think might be rheumatic fever caused by strep, They'll say, has your child had any infections lately? A sore throat, a pharyngitis? And of course, they probably have. Now, these children, to diagnose it completely, will do something called an ASO titer, anti-streptolysin titer. Strep, it's in the middle. It's telling you, is there strep in the body? And when we see it positive, this is something that's due to a strep infection. This child needs to be on antibiotics, but long term. Now, one of the things rheumatic fever can damage is the valve, the mitral valve. If the valve gets damaged, there's nothing we can do. It's damaged. All right. If it's not damaged yet, it's good because everything else will go away. All of the chorea, the different movements, the rashes, the joint swollen, all of that goes away, but not the heart. The heart valve will be damaged. And you think only old people get high cholesterol, right? Well, we've learned children have it too. We know children can have slow or fast or disturbances in their heart rates. It's normal, just like adults do. One of the other things that I think is prevalent, especially in children who are premature or with some cardiac conditions, is pulmonary artery hypertension. The lungs are tight and they don't exchange airway, and it basically it causes a lot of, just with a little bit of exertion, a lot of dyspnea, a lot of troubles with breathing. Cardiomyopathy, actually due to a viral state. Could happen in, or again, it could be that lupus, or it could be Tay-Sachs, or another thing that has caused the heart to stretch and become floppy and not work properly. Many of those end up getting a transplant. Now, you heard me talk about the hypoplastic left heart syndrome, right? That's a child who goes through 3 stages surgery and many times ends up with a transplant. The biggest reason for death in a transplant is rejection. The body says, no, I don't want you. It's rejection. Chest tubes and cardiac go hand in hand. If you're going to have surgery, you're going to have chest tubes following it. Know that, number one, never lie to a child. It's going to burn, it's going to hurt. But first, take vital signs, medicate them for pain, get on that child's level, explain what's going to happen, and be honest. Children are being checked earlier and earlier for blood pressure. I know it used to be age 5. Well, they're down to age 3 now that they're looking for it. Another condition is called Kawasaki. Kawasaki disease is one of these things that goes on for a while before we catch it. It's going to be a child's going to have a fever. It's going to just have this rash. Then they start with red eyes, and then their lips start to break. Their tongue turns strawberry. Their palms of their hands start to peel and blister. And it is a viral disease. And the body is what happens, it's called an acute systemic vascularitis. So the vessels get inflamed. Well, the one vessels that you're concerned about is the coronary arteries. They get inflamed, microembolus goes off, and it occludes, they have heart attacks. They also, because of it, get these aneurysms, blood can't flow, and they could pop an aneurysm and die from them. So, Kawasaki, what would you see? You would see a child who's been sick for 5, 7 days, and we really don't know what's going on. And you would see all of these symptoms. It's usually when you start seeing the palms and the soles of the feet with the peeling, the tongue strawberry. And I'm telling you, these are the biggest, reddest, most fluorescent strawberry eyes I've ever seen. You can see it. So how do we treat it? The virus. So we're going to be given intravenous gamma globulins, IVIG. Now, the other thing, because those vessels are inflamed and there's microemboli, we're going to put them on high dose aspirin. This is the only time you would recommend aspirin for your parent, okay? Another thing, they do sometimes put them on anticoagulants, your Coumadin, but mostly they try to be more benign and do aspirin. Remember, shock can happen in any age. Infants, children, the biggest one, it's due to an infection. Due to infection. Infants get sick quick and they go septic shock quick. Anaphylaxis, they've never had antibiotics medicine before. The chances of anaphylaxis are high. Just know that what to look for. And of course, you know where the epinephrine is, right? Septic shock, as I said, that's the number one that we see. I mean, early stages, is when elevated heart rate, blood pressure starts to drop. That's when you first start to see it. If it gets beyond that, and now going to bradycardia, that's late stages. I don't know if you're going to come back from that. Toxic shock, this is your adolescence. This is the tampon use. They finally realized that it can cause toxic shock. And then a question for y'all. Surgical closure of the patent ductus arteriosus would result in which of the following? Remember, your PDA is your oxygen giver. It takes the pulmonary artery and gives oxygen to the aorta. So if we stop it,
A.
it's going to stop the blood from going back. Yes, it is. So is that too much for you on a day like today? It's a lot of information, a lot of cardiac, a lot of things. I think that matching is going to help you through it. All right, let's go on with our cahoots. I think we have just enough time. Who wants to win today? Anybody? Linda, you look like you want to win today. No? You're laughing. Jasmine, what about you? Yeah? Jessica, I think you are. You and your daughter were happily listening to me earlier. Let's get going. Thank you, guys. Week 5. Unbelievable. Almost halfway there. A majority of upper respiratory infections are caused by, I think as a parent, this is one of the most frustrating things is when they tell you, as a virus, Tylenol, Motrin, and you made all that time to get in there and want an antibiotic. And they're telling you, no, it's a virus. I know I was when I was a young parent. Down's children are more susceptible to which medical conditions? You don't know all of them, but I told you about the heart. What else? This was a question I believe I saw in the Hesse about the Downs children. Downs children, cognitive delay, and how to deal with them. We are more apt to get hypothyroidism, leukemia. Believe it or not, they're more apt for leukemia. And they do get congenital heart defects like a VSD. And I don't know why that's not checked there. I apologize. You walk to a 6-year-old child's room and you find them not breathing and doesn't wake up. What are you going to do? Giving you a CPR question. So it is said now you don't do airway first. They figure there's enough oxygen in you now. That used to be that way. Now it's right to just compressions, and then you're hitting that code blue button above the bed. A multi. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? What are they going to look like? Children that don't feel well, they're usually in the corner, they're quiet, they don't want to eat, they might have a fever, they might vomit, their tummy might hurt, but our goal is get the fever down and get them drinking so that with the fever, we're taking care of that fluid loss. Multi. What do you look for when assessing respiratory function? How do you assess it? And one thing about children, you can look at them and know when they're not breathing right. Between their clavicles, it's sucking to the backbone, or their nasal flaring. Infants, nasal flaring and grunting. Those are things that you'll hear and that you'll see. And yes, all the above. What would you look for after a child has a tonsillectomy? One of the things about tonsillectomies, remember, there's these scabs in the back of their throat, and they can come off and they can bleed. If you see a child post TNA or just T, if you see them swallowing, they're bleeding. So you don't put anything in their mouth, nothing, no tongue depressor, nothing, but slightly open their mouth and you'll see the blood in there. Most likely, depending on how much they need to get to the back to the hospital, and many times recauterize that area in the OR. Nursing care for a child's status post tonsillectomy include so give them the medicine as they need so they can at least sip stuff. Gum for the ears for the older people. Ice bags if the kid will let you keep it there depending on the age of it, but keep them comfortable. Multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Or I told you this is the rough one to get. Usually the doctor today will give you cough medicine and a Z-Pack. The worst part about it is the cough. It's called bronchitis, and the other name, tracheobronchitis. It's the same name. Just know you'll see it interposed anyway said. Tracheobronchitis, bronchitis, same thing. Multi. What signs and symptoms would you see in a child with otitis media? Ear pain, absolutely. And usually your priority care on a child with otitis media is give him something for the pain. Because if you're going to give him the antibiotic, it's not going to take care of that pain right away. So take care of that pain. Sometimes I try to give them a heat pack and they don't want nothing to touch them. And remember, they don't always have a fever. I get earaches all the time. I never have a fever, but I know because I can feel it. The monthly immunization for RSV is Synagis palivizumab. Thank you so much. Good job. A 4-year-old child's been taking the medicines for asthma, but the child is still wheezing. information is important to ask here? Like if they're taking their meds, they're still wheezing. What do you need to know? Never assume that they're taking it properly. Let them show you how do you, if they're still wheezing, they're going to get the medicine. So do it. And if not, get them a spacer so that they can take it properly. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Now, an 8-month-old. So this is where you need to know things like what are pulses and what are normal ones. Is that elevated? Is that normal? You see, it's what I gave it to you. Those heart rates on an 8-month-old are perfectly normal. It is not exhibiting any sort of distress there. What you would see in this child is the retractions, and then because it's respiratory, that restlessness, they're getting hypoxic. 95 sats is fine for 8-month-old. Signs and symptoms of asthma include all except. So remember, I've told you two conditions. One, that we have inspiratory, can't get it in, that's your oral pharyngeal croup. And then you've got your asthma, which is air comes in, but it can't go out. So it's expiratory, trying to push it out there. It's a prolonged respiratory phase there. So very good. People with asthma, they're going to be coughing, wheezing, short of breath, and they're going to be air hungry. Shorten, prolong, try to get the air out. They can't. Signs and symptoms of congenital heart disease include all except. So if you had a child with a congenital heart disease, remember, if you have a congenital heart, that means your heart's beating more, it's working harder, right? Because it's trying to beat blood around with something that's missing. So this is a child because the heart's working more, is burning more calories. It's probably going to be in like the 10 percentile, 20 percentile of weight on the low side because they're burning so many calories. What should you not do to children diagnosed with croup and epiglottitis? So the thing is, you're not going to take, you can open a mouth, but you're not going to stick things in there and look really into that oral pharynx. It's just literally looking at a tongue. A multi. Treatment for infectious mononucleosis. Remember mononucleosis, it is really hard sometimes to diagnose. Remember that ASO titer? It's a strep infection, right? No, right? This is the one that's a virus. And this is the one that's no contact sports and rest. So no antibiotics, it's a virus. Protect that belly at all costs. Rest, and then of course your acetaminophen and your ibuprofen. And that's, you have to wait till the doctor clears to go back for contact sports. Multi. When due to admission on an infant has a low-grade fever and a loose cough, information is important to ask. So APGARs, it doesn't make a difference unless they were in in the NICU for months. But you have an infant coming in, it's going to be admitted. You need to place them properly. Immunization status is always number one. And then you want to know what their fevers were, when the medications were, so you can continue that ibuprofen or that acetaminophen, whatever is appropriate. What is the greatest risk for an infant having a cardiac catheterization? Our biggest concern, and I know it's mine, is those big holes that are left in there, and it's that hemorrhage. So check that first. With cystic fibrosis identified. So no stool at birth for the first 2 days of birth be the one thing that makes you suspicious. But then after that, you no stool, you're saying, let's do that newborn screening. It's that sweat test that's done at birth. And as I said, if the mother licked that child, it would be extremely salty. Another multi. What is included in a plan of care for a child with cystic fibrosis? So remember, cystic fibrosis is lungs and nutrition. It's not one thing. It's a very complex condition because you're not just dealing with keeping lungs open and moving, it's also making sure we're keeping this child nutritionally satisfied. So, aggressive chest physical therapy. Again, we do this all before they eat, making sure you clean, you're taught them how to clean the equipment every night before they go to bed because it's got all the germs from the day in there breathing in and out, right? Pancreatic enzymes with meals or snacks before, 30 minutes before, directly before, not 2 hours, right before they eat. And of course, high protein because they're not going to be getting fat. What is the drug of choice for a pharmacological closure of a PDA? So you've got that oxygen getter. You don't need it anymore. It needs to close. Next, the aorta to the pulmonary artery. And we can give some IV medication and we're going to be giving it. It's called indomethacin. Now, indomethacin is an NSAID and it closes the PDA. Prostaglandin is a hormone like mommy's, and that's to keep it open. Synergist is for your RSV. Vitamin K we give at birth. Stop bleeding. What is not a feature of tetralogy of Fallot? Well, tetralogy of Fallot is a right-sided heart problem. What there is not right-sided? And that's how that question is answered. The aorta is on the left side. You have your ventricles in the middle, so it can be on the right side. Right ventricular hypertrophy, right side. Pulmonary artery stenosis, yes. Tetralogy of Fallot is when blood gets stuck in the right ventricle and can't go into the lungs. It's a kink on that pulmonary artery, that valve. It doesn't let blood go through. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? So again, that might be your only clue is vomiting. Yeah, you might have a heart rate, yes, but that first clue is, let me check it before I give it. Why would a child with tetralogy Fallot not gain weight at the normal rate? And I think, this is one of those big concepts within congenital heart defects is they don't get enough oxygen, they don't have energy, and they don't eat enough. And that is basic concept of congenital heart defects. A multi. All are examples of cyanotic heart murmurs except. Well, I told you in the beginning, tetralogy of Fallot was the biggest cyanotic heart defect you're going to see on every exam, HESIs, exams, NCLEX, that's the one they like to use. Tricuspid atresia is when there's no opening between the right atrium and ventricle. Absolutely, it is cyanotic. Now, aortic stenosis is a narrowing of the valve that goes from the left ventricle to the body. It's not cyanotic. And an ASD is an atrial septal defect. It's a hole between the two chambers between the right and left side. It's not cyanotic. This is a question you're going to see things like that. Nursing care following a cardiac catheterization. So, big thing is we're going to assess that assertion site, slowly elevate that head of the bed, and you want to keep that extremity straight. You don't want it bent. You don't want pressure to be placed on the insertion site where they had those big catheters, okay? And they're 24 hours on bed rest following cardiac cath. Multi. Nursing education for the cardiac catheterization include all except so we'll monitor vital signs. Are we going to ambulate that child? Are we going to bend that extremity? Are we going to have a pressure dressing? Well, we're definitely not going to ambulate that child. We're definitely not going to bend that extremity. And all children, all ages will get a pressure dressing. They may not get a sandbag on top to hold it. That's older children. Which important information is most important when rheumatic fever is suspected? What's rheumatic fever caused by? Oh, rheumatic fever is due to a strep infection that wasn't treated. As we go to week 8, you're going to see acute glomerular nephritis can also be caused by strep infection. Can you see the importance of telling your parents for the child to complete the entire dose? So, signs of shock in children include all of the following except shock. What do you see? Everything except hypertension. What do you see in shock? Altered mental status, poor capillary refill, tachycardia, hypotension. Your body's beating a heartbeat so quick and trying to get a blood pressure, and you're going into shock. Hypertension is not part of that. Which of the following best describes the pathophysiology of Kawasaki disease? Kawasaki is multi-system vascular arteries, and we're worried about coronary arteries and aneurysm. So it's an itis, it's an inflammation, it's little microembolus, right? This is what you need to remember with Kawasaki. What's the treatment for it? So a clinical manifestation of Kawasaki is, and remember, Kawasaki um, has all of these things going on there, and we can turn it all back around. You're going to see blistered, cracked hands, strawberry tongue, red in eyes. We don't see chorea with Kawasaki, do we? Isn't that with your strep infection, your rheumatic fever? What is the treatment for Kawasaki disease? We have an itis, an inflammation. We're worried about blood clots. It's viral, so we need to boost the immune system. Aspirin, IVIG. See, this is how you should start thinking of these questions the way that I'm reading them to you now, okay? Which of the following is the most common cause of shock in infants and children? When we talk about shock in children, it is infection. Because remember, their body's not used to it. They can't fight it as well. It's our job, especially on these really young or immunosuppressed children, to catch it quick. You know what we usually see first is apneas and bradycardias. When we start to see that, something's going on. What are the defects associated with tetralogy of Fallot? Told you it's right-sided. So it's the pulmonary artery. It still has the hole between the ventricles, VSD. The aorta sort of gets pushed over. And because that closes off and doesn't let blood flow to the lungs, that right ventricle gets stretched. And that's hypertrophy. And that's what that means. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell? I mean, I do it for infants, but these young children that have it that are not repaired, all of a sudden they squat. And again, it just changes the pressure and it pops open the valve and it lets blood flow. Transposition of the great arteries is what? These children come in and, the parents are scared and, these children otherwise are perfectly normal. The aorta and the pulmonary artery are switched. The problem is we're not getting any oxygen. So this is the one that needs an oxygen getter. This is the one that will be placed on prostaglandins and will open up the patent ductus arteriosus until that child goes to surgery and good oxygen gets to that child. And you can wait a week or two if you need to. Which of the following is not an intervention indicated for transposition of great arteries? Well, let me tell you, probably one of the most severe and most complex of the conditions with apoplastic left heart. Those two are big ones with intervention that needs done. And I'll tell you with it, nothing oral is going to do nothing for this child. Nothing. Now, IVIG, just like I said, we want blood flowing, oxygen. And the arterial switches, what it means, it just picks it up, turns it around, and puts those arteries back where they need to go. And then sometimes this balloon atrial septostomy, they just make a bigger hole in the atrium so that blood can flow from the lungs into the body, okay? But oral, nothing works on these children. Why is prostaglandins given to a child with transposition of the great arteries? Ooh. So what is the goal of prostaglandins no matter what? It helps with oxygenation and it maintains cardiac output. It is not an antibiotic, so it is not endocarditis, it's not an infection. It's a hormone that keeps the patent ductus arteriosus open. When the prostaglandins is gone, it closes. So we do have that synthetic one to keep it open. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? Well, what keeps it open? Indomethacin closes it. So It inhibits the prostaglandins and it closes it. Okay? Indomethacin promotes closure of the duct. Where is the patent ductus arteriosus? Our oxygen keeper. Again, what is it connected to? And think of big vessels, not little vessels. It's the aorta, pulmonary artery. Think lungs, body. Lungs bring in oxygen to the body. Pulmonary artery, aorta. This heart defect allows blood to pass from the left ventricle to the right ventricle. What is that called? And that's the ventricular septal defect. If it was the left atrium and the right atrium, it's an atrial septal defect. A multi. What is signs of digitoxicity in infants? Infants. What's the sign of digitoxicity in infants? Nausea, vomiting, and a low heart rate. Absolutely. Can an infant tell you they're seeing yellow spots? No, that's more of the adults. And again, digitoxicity has nothing to do with an antibiotic. Left-sided congestive heart failure causes what? Left-sided aorta kinked, slow and going back. Where does it go? What happens? And it's all about congestive heart failure. And this is all about fluid in the lungs. Yes. After a heart transplant, what's the leading reason children die? And it's rejection, not infection, rejection. Multi. Signs and symptoms of rheumatic fever include rheumatic fever, it's respiratory, it's polyarthritis, big swollen nodules, that weird movement. Again, how do we diagnose? Have they had a strep infection? Treatment, long-term antibiotics. Multi. The child's about to have a chest tube removed. What should you do? I was lucky. I also worked in the adult open heart area also. And I used to work night shift. And first thing in the morning, 6 a.m., residents come around and pull chest tubes. So I remember those patients, these adults telling me it does burn like crazy. But temporary, just quickly, and then it's better. So again, take vital signs before, give them pain medicine, and let them know it's going to hurt, but it's going to be temporary. It's not for a long time. And again, everything on the level of the child. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's your priority? They just have abdominal surgery. They can't cough. That's not a good thing. So what's your priority? How are you going to make that happen? Number one, you have a child, an adult who needs to cough, deep breathe, get out of bed, ambulate, whatever, and they've just had surgery. Number one, medicate them for pain so that they can get up and move and do it well. Then they can get out of bed using incentive spirometry, deep breathe, cough, do what you want, but pain medicine, priority, number one. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Oh, excuse me. You cannot give ibuprofen or aspirin or anything else but acetaminophen to an infant less than 6 months old. At 6 months, you may add ibuprofen. A newborn infant is assessed. The nurse finds very weak lower extremity pulses. What should she assess next? What did I tell you about finding weak pulses? Dorsalis pedis, posterior tibial, they're weak, they're non-existent. It's a newborn. What are you going to look at next? What do you think you're diagnosing here? Next thing is that for extremity blood pressure. I'm looking for coarctation of aorta, right? Lower extremities very weak. Blood's not flowing. What condition causes that? Kink of the hose, blood can't go. Coarctation. Lower blood pressure on the lower extremities and higher on the upper extremities. Multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? Because a child, you think that they can't get bed sores and foot drops and all of those things. And I'm telling you, they can. So what do we do is, well, of course, anything to cough, deep breathe, whatnot, keep the child dry, whether they're diapers or chucks or whatever. Pillows, blankets. I would use, those little toys, stuffy toys, holding ET tubes, holding their heads, their hands, hugging teddy bears between their legs, blankets, and all of these things, and then moving every 2 hours, and rubbing them, and preventing them from getting those sort of side effects of getting like their oops. So how can oxygen be delivered that is easiest tolerated and accurately monitored? This is one of those chapter 39 questions. It's, what's better for a child, an infant? Well, infants, we can put on a nasal cannula and we're going to tape it and they're going to take and they're going to rip it off and it tickles and they're not going to like it. Put them on that little clear plastic. They can suck fingers, pacifier, whatever they want, and look around. And it is really well regulated. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? The thing about cystic fibrosis, there's such thick mucus in there. We don't keep really active, good chest CPT, deep breathing, aerosols, etc. It clogs up and there's no oxygenation that's going to go on. So, what do we need to do? Deep breathe, exercise, chest PT, and ambulate PRN, ambulate QID, Q6, Q2, not just PRN. Sigh. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Okay, pancreatic enzymes are there. It helps with digestion, especially of the fat. Now, how do we take them so that they work most effectively? That's the answer, right? Remember, we take them immediately before meals. If it has a capsule, you can sprinkle it. If it has powder, you also can sprinkle it, but make sure that mouth is rinsed out. And then the one thing that I say that we always forget to do is as the child grows, the dose should be increased, it should be changed. What is a cardiac defect? There is no valve between the right atrium and the right ventricle. and it's called tricuspid atresia. Tetralogy of Fallot is the pulmonary artery, which is in the right ventricle. And last question. When an infant is breathing fast, tires easy, and needs rest periods during feeding, what should you assess? What do you think is going on here? And this could be sudden. They could be fine not doing this, yesterday, and you come in today and what's going on with this child? And most likely they're going into congestive failure. Cindy, good job, Cindy. Number two, yo. Number one, meat. Good job, meat. And a key and a Jess. So anyway, we're done with today. I mean, week 5 is a hard week. It's a lot of stuff. If you need help with it, let me know. I think that just having that guide that I gave you, that worksheet, will help you with the understanding. But if you need more than that, you let me know. So next week is going to be reviews again. I'll be sending out, the reviews when they are. They're going over the same schedule as they did last exam. Again, they'll all be posted for you as I get them. Any questions, anybody? Good night, everybody.
Good night. Thank you.
You're welcome.